again, under consensus by Iceland, that was representing an important platform of member states in Geneva, and the Philippines. The Philippines negotiated this resolution. And this workshop, this seminar, is part of the implementation of this Human Rights Council resolution. My presence here as a representative of the United Nations country team in the is to confirm our commitment, the commitment of the United Nations, to be part of the solution, hand in hand with concerned partners in addressing the human impact of the so-called war on drugs in the country. We are not observers. We would like to be part of the solution. And now let me just share with you the philosophical part of my speech. So when you look at the title of this workshop, is intriguing. It's a strange title, Compassionate and Pragmatism. And sometimes these two terms, they are in opposite place. No? Compassionate means a genuine concern for others. It reflects a deep sense of care, of empathy, and of attention to others. This is very much related to the traditional concept of solidarity in the Philippines. So to be compassionate, we start by recognizing that we live in a diverse society where we bring different cultural backgrounds, religious ideologies, gender, values, among others. And we frequently say that diversity is our strength, not our weakness. Pragmatism, on the other hand, centers on practical acts and care. To be pragmatic means to find concrete and factual ways to translate ideas, goals into action. Pragmatism, in the context of today's workshop, means finding solutions that are based on evidence, on facts, and still more important, on the experience of people, and particularly those who are more involved in and affected by substance use. At the end of the day, being compassionate and being pragmatic is also an expression of being humble, is to look at others, to recognize the specificity of this country, people, and to find solutions that they take into account this specificity. And let me just share with you an example of the importance of this approach that recognizes the specificity of each country. Because certainly our strategy in addressing drug use here in the Philippines is going to be quite different from my own country, Argentina, Thailand, and the US, certainly. So let me just share with you this compassionate pragmatism in action. The Philippines has an alarming and rapidly increasing HIV and hepatitis C prevalence. This is considered a twin epidemic among people who use drugs. Many countries, including Southeast Asian member states, have implemented comprehensive and evidence-based interventions based on the guidelines of the International Office of Drugs and Crime, UNAIDS, and the World Health Organization that have shown tremendous positive results. In front of this challenge, if we just remain with the pure enforcement approach that stigmatize and discriminate, of course we will remain in our comfort zones of a simplistic approach, but with the failure of not funding the solution. Last month, the United Nations Human Rights Council adopted a resolution on drugs policy and human rights. In this resolution, the Council recalled that efforts to achieve the Sustainable Development Goals, the SDGs, and to effectively address all aspects of the drugs problem are complementary and mutually reinforcing, and that public health programs should be available to all. This needs to be implemented without discrimination, including for individuals with drug use disorders, as well as in prisons and other custodial settings. It is crucial that we reflect and consider which responses will work most effectively in the Philippines, particularly to prevent and address drug use disorders from a holistic perspective. And let me just go back to the recent statement of the President of the Republic of the Philippines, and I quote, "We are looking at the problem as a whole, giving options to our young people so they are not tempted to push in these activities." Today's workshop is also implemented, as you know, as part of the United Nations Joint Program on Human Rights in the Philippines, which is an important platform for creating solutions to drug-related issues in the country. And of course, I thank our development partners, as I mentioned, represented here by the Australian Embassy and the Royal Mauritian Embassy and the Global Fund for their support in this endeavor. I also commend the growing cooperation among the Philippine government, the Commission on Human Rights, civil society organizations on public health and human rights. So dear partners, dear friends, let us show the world how we in the Philippines can work with compassion and with pragmatism, with respect human rights of all, including people who use drugs, to implement the most effective solution. Thank you very much and welcome once again. Maraming salamat.
Thank you very much, President, for let us very slides. The United Nations Joint Program for Human Rights, the Human Rights-Based Approach to Drug Control Component, is co-chaired by our chairperson of the Dangerous Drugs Forum. He has prepared a video message for us all. Let us welcome Secretary Catalina Ascuri with a warm round of applause.
Distinguished guests, representatives from the United Nations Joint Program on Human Rights Technical Working Group, federal government officials, civil society representatives, and international partners, good morning. Recently, I represented the Dangerous Drugs Board as an official delegate of the Philippines to the 66th Commission on Narcotics and Drugs, CND, in Vienna, Austria. There, we emphasized and discussed in our country statement the core functions of the Philippine anti-illegal strategy that is being enforced as a whole-of-nation approach which unites, balances, and strengthens complementing law enforcement and public health strategies. As everyone here knows, the Philippine anti-drug strategy, or PADS, is grounded on evidence-based and culturally appropriate strategies attuned to Philippine values and tailored to fit the socio-cultural context. It is a comprehensive and balanced approach that puts significant premium on both drug supply and drug demand reduction efforts and initiatives. PADS is intersectoral and participatory. It brings together the different efforts of our diverse stakeholders, the families, schools, communities, workplaces, civic groups, the youth, media, and faith-based organizations. Various drug demand reduction programs and prevention settings have been utilized in the country. For families, the Dangerous Drugs Board designed programs such as the systematic training for a parenting program, the Parent Youth Resource Against Drug Abuse Prevention, and the Drug Abuse Prevention Program for the families of overseas Philippine workers, to name it. While the Department of Social Welfare and Development disseminates the Family Drug Abuse Prevention Program, in the school setting, the Department of Education developed a unified framework on preventive drug education to further strengthen the delivery of its national drug education program. Its major strategy is delivering universal prevention through the Barcada contra Droga, a peer group against drugs in all schools. For the work setting, all government agencies have established their respective drug-free workplace policies and programs. For the community, the Department of Health, with the Department of the Interior and all government, spearheads preventive drug education that targets the general public, persons who use drugs, their families, and the service providers. The Department of Health also launched a helpline, a frontline initiative dedicated to provide key information and support regarding available treatment options, rehabilitation and recovery interventions, referral network, and support services for telephone and online services. Our local government units are directed to strengthen the anti-illegal drug abuse councils to work in partnership with the law enforcement in the handling of drug-related cases and coordinate with the Department of Health for the assessment and management of persons who use drugs. At the moment, the Department of Interior and Law is also implementing its BIDA program, which stands for Buhay Ingatan, Turagay Ayawan. Our supply reduction efforts involve aggressive law enforcement and prosecution, which adheres to the rule of law and to the fundamentals of human rights, coupled with comprehensive demand reduction initiatives and supported by strong regional and international ties. While other countries adopt the harm reduction as a strategy in the campaign to address drug abuse, our Philippine anti-drug strategy does not include it as an approach to resolve the drug problem. This is because there are practices and principles in it that are in contrast with the goals of rehabilitation programs in the Philippines. Furthermore, some of the concepts of harm reduction vary and run counter to existing rehabilitation policies and programs. Specifically, harm reduction covers a wide range of health and social concerns such as community management of opioid overdoses, needles and syringe distribution, overdose prevention sites, non-abstinence housing, among others, which are controversial and violate existing Philippine drug policies and rules. Thus, today, we are aligning our focus on strengthening the rehabilitation program and building more community-based drug rehabilitation centers, not only in the national capital region, but also in far-flung areas of the country, as directly from the President Marcos Jr. As we intensify the anti-illegal drug campaign with the government, we also strengthen the support to anti-drug abuse councils at all levels and to the community-based drug treatment and rehabilitation centers all over the country to assist all persons who use drugs. Voluntary rehabilitation is also offered to persons with these drugs who are willing to undergo proper and holistic interventions. We always believe that drug addiction is a disease and can be. As of 31 December 20, the Philippines has a total of 81 public and private drug treatment and rehabilitation centers nationwide that are all accredited by the Department of Health. We have 5 information centers inside detention facilities being run by the Bureau of Jail Management and Technology and the Bureau of Corrections, and 62 community-based drug rehabilitation centers. These facilities are still growing as we speak. In general, this mutually reinforcing supply and demand reduction approaches put emphasis on achieving proportionality of efforts, resources, and investments to achieve drug-resistant and eventually drug-free communities. Thank you very much and a pleasant morning.
Thank you very much, Secretary, for your message and for letting us understand where we are now. Our two international development partners are also here to make solidarity messages. They invite Mr. Alexander Harrop, Australian Embassy for this.
Good morning, everyone. Firstly, I want to echo the acknowledgements received on with us this morning, His Excellency Gustavo Gonzalez, the University of Mesa, my colleague, Royal University, Pearson, distinguished guests from across the Philippines and the and from various government agencies. Magandang umaga sa inyo. On behalf of the Australian Embassy, I really want to thank you for the opportunity for a guest of the board here at this Compassionate Pragmatism. Firstly, I'd like to particularly commend and appreciate the commitment of youths to a more inclusive, passionate, and effective approach to substance use, control, and prevention. I am particularly impressed by the fact that we introduced with us today, I understand, from Sahez, from Guy and Oro, and also from Mandela. I don't think it's any surprise to say that substance use and addiction is a significant public health issue, both in Australia and in the Philippines. Having this dialogue is a critical first step to understand how we can support health and social care for people with drugs. In Australia, our National Drug Strategy, 2017 to 2026, focuses on building healthy, safe, and resilient communities by minimising health, social, and economic harms of alcohol, tobacco, illicit drugs, and also pharmaceutical drug use and misuse. We recognise that drug use impacts everyone and is linked to discrimination, unemployment, homelessness, poverty, and also family breakdowns. We are continuously trying to improve our own harm reduction and minimisation strategy, for example, by incorporating best practice and latest evidence-informed treatments and increasing participatory processes. As a founding member of the UN Joint Programme in the Philippines, Australia is incredibly pleased and grateful that we know to play a small role in the success of this initiative and today's dialogue. As one of the first and one of the largest donors, today we have provided 49 million pesos in funding to the UN Joint Programme. I am confident that this week's workshop further strengthens the hard work, technical work, and human rights-based approaches to drug use, which has been working towards operationalising the work plan for the strategic created this year. For Australia, we are absolutely committed to being a constructive human rights partner to the Philippines, and particularly in this area. The Embassy wishes all participants a productive and fruitful. I look forward to hearing the lessons learned and how these will be operationalised in LGUs across the country. Maraming salamat.
Thank you very much, Mr. O'Hara. And to give a solidarity message on behalf of the Royal Philippines, let's most welcome to their highlights.
Good morning, everyone. Gustavo, my representatives, both from different areas of government, areas, dear friends, I'm very honored to be here today, and I hope this will be the start of a very good workshop. And allow me to start by congratulating the UN, the government, in our joint cooperation on benefits for the program. Very long sentence. The UNJP is very important. It's very important for peace, very important for the way the Philippines is supported nationally. Norway, like my predecessor mentioned, Australia is one of the first countries to support the success. And I have to say that being here documents this is one of the successes. But through the work of UNODC, we're also pleased that work on Article 6 has very significant process. What is Article 6? It's the European rights-based approach to planning. When the Universal Philippines accepted 215 out of 289 nations. And the acceptance of these is this country also a great it also goes to put forward and advance the cause of human rights internationally fighting with the country working for human rights. So thank you. Human rights is, of course, very important in Norway. It's a forward always adherence, multilateralism, core values, and also the basis for trying to achieve for global space order. Norway supports the Philippines in its quest for the best ways to protect citizens, societies from the harm caused by others, but also to assist those who have fallen under the subsidies. They are victims. They may be criminals at times, they're also victims. And the human rights-based approach is so important for investigation. And Norway also welcomes the programming partners like this, looking into the global literature, best practice for health in addressing this challenge. The key element. We welcome results and improvements chart group based on evidence. Here is also evidence what works. And that has to be the way forward. Solution. And it's been really good comes on out of this meeting, this workshop, which will bring human rights-based focus on substance abuse forward in the Philippines. Thank you all.
Thank you very much, Mr. Michael. The public health approach to substance use is an important work under the Global Fund being implemented through our partner, Pilipinas Shell Foundation for Parents. To give a message on their behalf, let's please welcome Dr. Lloyd Brandon Morales.
Thank you, Lee, and good morning to everyone.
Magandang umaga po sa ating lahat. On behalf of the Pilipinas Shell Foundation, we are very pleased to be part
The Pilipinas Foundation is the research recipient of the Global Fund grant of positive. Consultation. There is a series of consultations that will fill the pulse and seek better inputs from our stakeholders and for us to together identify ways forward. How can we together our resources, our hearts and minds, and our commitments together so that we can create impact for the communities that so for the global fund, we are committed to supporting government series of consultations, both national and local, working together. And then also we have submitted to the fund request for the next round, which is going to be from years 2024 to 2026, and we need a minimum of 10 billion pesos for the implementation of principle on reduction slash compassionate pragmatism research, which will help identify whether reduction of harm interventions will have a significant impact, say, the harm against HIV and STI among our population. Right? So the funding request is going to review the global fund. There will be from the Philippines the next in the coming weeks, and hopefully get that or that campaign in half of the Philippines Corporation. Look forward to working closely with the UNODC with all our development partners or present our partners as well in the oceans and the various local and the national level agencies in order to come up with significant interventions that will help address the challenge not only of HIV and STIs among preventive population as well. So,
you very much, Dr. Morello, for the support of the culture. In 2021, the United Nations, together with the government of the Philippines, including the Commission on Human Rights, Civil Society, entered into the UN Joint Program, Technical Cooperation and Capacity Building for the Promotion and Protection of Human Rights in the Philippines. The JBHR focuses on 6 key areas, including the human rights-based approach to drugs, On November 21, 2020, the members of the Technical Working Group on HRD drugs completed part on hand and developed its plan, including agreements on its goals and strategic objectives. This work plan was then approved by the Steering Committee of the UN Joint Program on Human Rights on December 5, 2020. We would like to present to you the Antipolo Declaration, which embodies the goals and strategic objectives of the HRD drugs control. I call on the stage our UNODC Senior Policy Advisor and Co-Chair of the HRD Drugs Technical Working Group, Mr. Olivier Hiller.
Please concerned that with my old age I could not read the declaration. I still can. Whereas the United Nations, together with the Philippine government, including the Commission on Human Rights, the civil society, in the spirit of partnership, trust building, and constructive engagement, have entered into the UN Joint Program for Human Rights. Whereas the joint program, with a view to further improving the situation of human rights individuals, convene the technical working group on human rights-based approaches to drug, or TWG, or HRBA drugs, or HAPIC, as we call our group for some time. In view, whereas the technical working group on human rights-based approach to drugs developed its goal and strategic objectives for the joint program, which was subsequently approved by the Steering Committee on December 5th, 2022. In view of the foregoing, we hereby declare, through this Antipolo Declaration, our collective aims toward the public health approach to substance use through the following. Number one, increase the availability and voluntary access to a range of appropriate human rights-based and scientifically informed services that include health, social, and developmental support for persons whose lives include drugs. Increase the capacity to address cross-cutting issues in drug control, according to the Nelson Mandela Rules, the Bangkok Rules, the Havana Rules, among others. Strengthen international cooperation on drug control based on the principle of common and shared responsibility in line with international standards. Strengthen joint action at national, regional, and international levels to accelerate the implementation of joint commitments to address the drug problem. Number four, develop and implement a communication strategy on human rights-based approach to drugs. The joint program will work toward the fulfillment of these strategic objectives through cohesive approaches and joint efforts of the United Nations, Philippine government, including the Commission on Human Rights and Civil Society. This is declared on this May 8, 2023, in Antipolo City, Philippines.
Thank you very much, Olivier. Olivier, for inviting you to in the school. As we now recognize the members of the Technical Working Group on HRD drugs who have worked hard and developed the goals and principles espoused in the Antipolo Declaration. They are at the core of implementing the activities geared towards establishing a public health approach to substance use. May I please request a representative from each office to come to the stage as I call on your agency. From the Department of Justice, Ms. Juana in the stage. From the World Health Organization, from UNAIDS, from UN Women, from the Supreme Court, Office of the Court Administrator, from the Philippine Public Safety College, from the Philippine National Police, from the Department of Education, from the Philippine Drug Enforcement Agency, from the Parole and Probation Administration, the Department of Social Welfare and Development, from the Department of Health, from the Department of Interior and Local Government, from the Commission on Human Rights, from the Bureau of Corrections, from the Bureau of Jail Management and Penology, from our civil society partners, Street Law Philippines, No Box Philippines, Asian Center for Drug Policy, from the Dangerous Drugs Board, and of course, from OHCHR and our resident coordinator. Please join us here in the stage as we take a photo opportunity to commemorate this very momentous occasion. Ms. Joanne, may I ask you also as the co-chair of the I hope I did not miss any member of the technical working. So let's take a first photo. Right. And then we'll have another photo which embodies compassionate pragmatism. May I request the one hand on your heart and the welcoming left hand which mentions work and pragmatism offering it to heartfelt. Okay, let's take a photo. And finally, for our Gen Z colleagues, let's do a selfie. Alright. Everyone. Okay, it's quite hard to capture everyone. Alright, here. One. One more. One. Go. Thank you very much, everyone. The public health approach to substance use in the Philippines is undertaken under the leadership of our Department of Health. To start our dialogue and session on the public health landscape, context and overview of health governance and policy directions for substance use, let us welcome the Department of Health focal person for drugs from the Public Health Services team, Mr. Jude Deval Santos.
Good morning everyone. Magandang umaga po ating lahat. I'm speaking on behalf of Public Health Services Secretary, February Lorraine po, and Public Cars. First topic. To a public health or drug control began with the drug trafficking thousand, which the infrastructure, the human resources, and deliverable, assisting and future drug abuse treatment and rehabilitation to the Department of Health. At that time, only court ordered confinement application was recognized by the law. This was expanded by the Dangerous Drugs Board Regulation Number 1, Series of 2009, to accommodate worker enrollment into an outpatient rehabilitation program for drug users who are not drug related. Further, further development, further development following resolution series of 2009 tells me to establish the pilot community-based facility type co-developed with the World Health Organization provide this proceed to the second. I well, as I was saying, we're presenting what shifted to a public for drug and the comprehensive aim that for existing drug use parts of and things as well for regulating into amount of users or not. Further, for years of 2000, published by Margaret Robertson. Recognition for the original intervention that to or series of which guides community-based drug rehabilitation programs and screening, treatment, and rehabilitation for low-risk drug users, including the provision of conditions to facilitate law enforcement efforts to develop government it takes a large portion of our spend. Very important to our health is the combined influence of our environment, our socio-economic health promotion is to make it so that our physical and social environments are healthy, so that regardless of our socioeconomic background, we're able to practice healthy behaviors, thereby helping people achieve the highest possible. For then access to care, we have to look at health more holistically in collaboration with our sectors. We're able to protect and enable to care for themselves and their community, taking into account the various factors that poor health or disease among not just providing care when it gets supported. The health promotion framework strategy for life. Framework, direction and strategies for the planning, development of policies, programs for the period 2021 to 20. The health promotion strategy. Just require it's very healthy. Health and immune are present and achieve health just possible. The mission is to make healthy behaviors the easier choice for everyone, anytime, everywhere, and making all Filipinos health literate settings where we spend most of our time in our health enabling and all public policies across all sectors. Recognizing the individual's structural influence on health seeking behaviors, health promotion interventions on the foregoing risk factors and action areas will be anchored on life stage and setting, rather than focusing on a single life, a life course approach. The implementation considers different stages, transitions, and settings where large differences can be made, promoting health and well-being. The health promotion framework strategy also recognizes that health should be promoted through life-first approach and self-behaviors are shaped by the present action, social, and the support that it provides strong norms, cultures, and qualities and other attributes. Still, in the sense, technologies that health is created and made by both citizens their everyday life, where they learn, work, and live. The health promotion framework that is to a settings-based approach that accelerates health by creating health supportive environment. Policies are helpful creating physical structures that are conducive to health, ensuring quality health services are available for the all members, guided by the universal health care. To build on past efforts, the health sector pursues an integrated, studies-based approach to the problem of social In the next slide, it shows that further to the mentioned universal health care, the mental health treats drug dependency as a mental health, and it redirects our efforts towards the institutionalization and for community-based management of mental, neurological, and substance use, or MNS. It also directs the public health network to strengthen our health system components for the next slide. Building on the efforts from the disease prevention, which handles the mental health prevention and the health promotion group under the public health services under the leadership of Assistant Paul and her secretary OIC Maria Rosado. The health sector should build on existing policies and include to operationalize public health for clinical practice guidance, preparing the pipeline and these are its recommendations to optimize patient care by reducing variation practice and resources or inform a systematic and assess
Kailangan niyo pa po ng
the mental health system promotion vehicle under the health promotion algorithm. This is also currently in development and as a guide in localizing various community interventions that keep their health. In support of the administration direction for a preventive approach in substance use, health department recommend utilizing public health approach to drugs and this will include on continuum of care from promoted preventive treatment activity. So the Department of Health adopted the health set, which include public points in approach to health promotion. Able under the health promotion bureau to serve as a guide for localizing this intervention and with our partners from the ILG this program. We expect to launch with community-based prevention. Each table will contain the following. So there is food, dental policy, legal basic resource, and more understanding. Efforts for health promotion in Brazil started in settings where we spend most of our time and this will be signed for communities of youth sections that they will leaders of will interact stricter organized and then system of proactive for healthy schools, all learning institutions, the big designated healthy setting, and shall formulate prudential analysis to be integrated programs that operate. For healthy workplaces, currently we have recently signed joint administrative on DOH, Dole, and also to the health, safety, and well-being of the workforce to promote and protect health promotion Tidak mengikuti bahasa department dan selamat.
Thank you very much, Mr. Gabasanos. It's very inspiring actually to hear the general health directions now of the Department of Health. What's particularly struck me first was the discussion on the social determinants to health. So now our government is recognizing that when we talk about health, it's not just about a biomedical perspective. It's not just about looking at certain conditions or illnesses, but it's really looking at how do we make people healthy. How do we make sure that we have healthy schools, healthy workplaces, healthy communities? And we also like the discussion on deinstitutionalization, focusing now on mental health and health promotion and working towards more community-based efforts. And I think because we have local government groups here, we will play an important role in fulfilling that vision of our Department of Health towards deinstitutionalization, bringing back people who use drugs to their families, to their friends, and to their communities, away from close settings. And finally, I like the idea that we're now putting it line with universal health care. When we say universal health care, it means by virtue of being a Filipino, you are entitled to a right to health. And that framework is very beautiful under the UN Joint Program for Human Rights. It operationalizes how do we promote health under a rights perspective. So thank you very much for that, Mr. Babalsa. Our second session will be a regional perspective on compassionate pragmatism. The public health approach to substance use, embodying the principles of compassion and pragmatism, is actually well underway in our neighboring countries in Southeast Asian. We have prepared a virtual panel with the support of our regional office.
panel, and I'm really sure that they're going to share some of the good practices that have been achieved in their countries. Before we begin, please allow me to introduce the members of the panel who also happen to be good colleagues. We have joining us from Vietnam, Dr. Kang Nguyen Tan. He's a medical professional graduating from Hanoi Medical University in 1998. He also possesses a master's degree in public health, specializing in health research from Hanoi Medical University. He's worked as a clinical physician. He has also worked within provincial hospitals in Vietnam, and he started working as a medical specialist for several international and non-profit organizations, including Médecins du Monde, Family Health International, and Population Services International. He has been responsible for overseeing diverse healthcare programs and projects, including HIV, TB, viral hepatitis treatments and care in preventing mother-to-child transmission, including, as you will probably hear through his presentation, supporting the work of opioid substitution therapy in Vietnam. Quang has an extensive background and experience, also working with UNODC for several years already, and we're really happy to have him on the team. Today from Indonesia, we've got our colleague Ali, or his nickname is Ali, but he's also known as Ade Olia. He is
Lahat ng
working as
lumalabas
National
sa
Project
speaker.
Officer for
Ito yun.
Demand Reduction and HIV at the Indonesia Program Office of UNODC. His role is to support development, management, and implementation functions of UNODC as it relates to drug demand reduction and HIV prevention in the country. Additionally, he's worked as a program coordinator, accountable to provide technical assistance, develop guidance, advocacy, and policy formulation for government counterparts, communities, and civil society organizations. He is also certified as a national trainer on the harm reduction program, and he's got over 23 years of experience in that field of harm reduction. He holds a bachelor's in psychology and a master's in public administration. Last but not least, from Myanmar, I'm very pleased to welcome Dr. Winmar. She's a public health development specialist with more than 20 years of experience working with governments, UN, NGO, and civil society organizations in HIV/AIDS, drugs and health, including just social development. Winmar is currently serving as our national program specialist, and she's covering the areas of prevention, treatment, and HIV prevention for people who use drugs, including in prison settings. Prior to joining UNODC, she has worked as a national project coordinator with UNDP in Myanmar, and her previous experience encompasses advocacy, coordination, partnership, policy dialogue, and advice. She also has very strong experience in financial management, human resource management, and FME. Her academic background is a medical doctor and her specialties are public health and development. She holds also masters in public health and a master's in development studies. So our panel is, as you can hear, very well qualified to speak on topics that will be presented heavily for a diverse range of experiences, not only as medical experts. Although, first up, I would like to on what Myanmar has been doing around harm reduction, or also known as compassionate pragmatism. Myanmar, the floor is yours.
Thank you, Karen. Good morning, everyone. Firstly, I would like to express my sincere thanks to Karen and my colleagues from the UNODC Philippines for giving me this opportunity to participate in this very important panel discussion as one of the panel members. So please let me share my brief presentation. The outlines of my presentations include the brief country situation and key progress, focuses on harm reductions, and then also UNODC contribution to the response on drugs and its health consequences, also particularly for harm reduction. And then I will present the key challenges and key take-home messages. So, as you all may aware that Myanmar is the second largest source of the opium in the world and one of the largest producers of the methamphetamine. And the estimated number of the people who injure drugs is more than 90,000, and then around the 30% of the are living with the HIV. It is the highest among the key populations, and but very low HIV status knowledge only 38%, and treatment coverage is also very low, 14%. The prevalence of the hepatitis B and C is very high among the people. It's a 7.7% and 56% respectively. Our country methadone treatment was started in 2006. Now the number of the clients of the methadone is around 25,000. It means that 30% of the people will receive the methadone maintenance therapy. So, regarding the key problems, actually, our country, the harm reduction was officially endorsed in the NEMA in the mid 2000. It means that more than a decade ago. But however, the available data showed that a large number of the people remains unreached, especially in the remote areas and conflict areas. They are very limited reasons for limited access and availability of economic banking services for both the intended drug user and people who consume the drugs. One of the barriers is the legal and policy environment. It is one of the barriers to access the healthcare services, outreach work, and community mobilization. Another important problem is we need to strengthen the multi-sectorial cooperation like the law enforcement, service providers, NGO, CDO networks, and also including the development and technical partners and their involvement. Another next problem is the community resistance to the harm reduction services like other countries, particularly the faith-based groups. Particularly the resistance to the distribution of the steroid measures and syringes because we have mixed concession tests. The distribution and steroid measures and syringes encourage the drug use. Like in other countries, stigma and discrimination within the family, community, health and social status, and also the family constraints. To my country, there's another key problem is the political instability. So, to sort out these problems and we are going to see supported the response of the trust and its consequences, regarding the legal and policy reforms, we generally see Myanmar provided the technical support to the development of the new national drug control policy and the amendment of the 1993 drug law. Because until 2017, Myanmar drug policy is mainly focused on the repression of the drug use and the drug-free country, and the policy address is mainly focused on primarily drug use and crime. That's why we supported to the development of the new drug control policy by doing a series of the consultation meeting with the all stakeholders, including the government agency, UNs, the development partners, and also the CDO and community network. So there's a many progress in the legal policy reform like that. We developed and launched the new national drug control policy in 2018. This policy is a very good policy and is a balanced and comprehensive and focused approach. And harm reduction is one of the policy area, and the policy suggested that decriminalization of the drug use and it is also included in the increased compliance with the human rights and cross-cutting issues. Also, we amended of the 1993 drug law is approved in 2018. The key changes is the removal of the compulsory registration of the keyword and the law is the inclusion of the harm reduction services and the switching from the imprisonment to the drug treatment. In addition, based on this law and the policy, we provided the development and adoption of the national strategic framework of drug control and national strategic framework of health and drugs in 2020. The national strategic framework of health and drugs is a focus on a comprehensive approach to address the health, social, and legal consequences of the drug use. In addition to that, we also provided the training on drug policy, harm reduction, alternatives to imprisonment, legal networks, and non-association to enhance their knowledge capacity. And these are the national drug control policy we published and launched in the 2018 in both Myanmar and English version, and also the Information Administrative Framework on Health Drugs. This is a very comprehensive approach to address social and legal consequences of drug use in Myanmar in 2020, and we also the Administrative Framework for the drug control in 2020. So we supported to enhance the multi-sectorial coordination because in Myanmar, methadone international therapy is primarily run by the public sector, and the research program is so this program has not been related to the national health system. That's why we need to enhance the multi-sectorial coordination. That's why we supported the establishment and function of the national drug user technical working group at the national level and township steering committee for anti-national services at the strategic township level, including all stakeholders, including the law enforcement, health, NGO drives, and network. This committee and this working group to share the update and issues and problem and to sort out the problem and issue collectively. This is the very good coordination mechanism. And now to reduce the community resistance, we do the continued advocacy and community mobilization, and with some strategic councils, we establish the village-based committee, and identify the ones champion for the community and we promote implementing the community and peer evaluation services by the CSO. And our aim is to provide technical support. And to reduce the stigma and discrimination, we are noticing Myanmar conducted a discrimination analysis of the stigma and discrimination among the drug user, particularly youth and women, who interest in 2020, and now we have full activity based on the findings and recommendations in partnership with the CSOs. We have a lot of progress in the sanitation services. We are stay at the key challenges. These are the one is there is still no by law for the amendment of the drug law yet, and law drug is not criminal. But the problem is the personal processing of the drug is still criminal. They stay 3 to 5 years of imprisonment, and there is no distinct difference between the drug use, drug dealers, and the traffickers. So there is disproportioning of the sentences. This is a very challenges in the amendment of the drug law. Another challenge is that there is a significant between the drug policy and the practice at the level of the community. That's something I like to change in the Myanmar's current post-school environment. Another key challenge is the lack of the gender-centered HIV services for women who injure drugs, not only the HIV service, but also the sexual and reproductive health service, gender violence, and maternal and child health care. Also, we have this initiated government-led and peer-led harmonization initiative in the South Asian Battle State Limited. Another thing is that we have no West Diplomat, we present other groups setting for the continuum of care, and then repeat again that political instability and escalating of conflicts after in early 2021 is the key challenges for our country. So this is the last slide for my presentation. I will share the key takeaway messages. So for the harm reduction services, we need to promote the environment should be favorable legal and policy environment together with the increasing awareness of the police and law enforcement effectiveness. Also, we need to apply the principle of the all inclusive and law and policy reform process. It is needed to include all the process like the all key stakeholders such as lawmakers, policy decision makers, service provider, academic, CBO, including trades and network and technical development partners. Now another important thing is because the law and policy reform is a very lengthy process, sometimes it takes 2 to 3 years. Our country is the one we took the time for the 1.5 years. So we need to strengthen the multi-sectorial cooperation at the national and local level whether it is support and uniform environment, because drug use and drug and health is not only the issue, but also the drugs and social the development and legal issues is an important issue. That's why multi-sectoral cooperation is very important. Another thing is that for the harm reduction, particularly for the harm, we need to do continuous advocacy at all level and community mobilization for the acceptance for harm reduction services and capacity for the community for the BLS harm reduction services. Lastly, but not least, we need to empower our people who for their meaningful involvement in any stage of the harm reduction program and ensure greater access to justice. So that's all my presentation. Thank you so much. Any comments and questions? Over to Karen.
Thank you very much, Rima. This was really insightful, and there's a few things that came up from your presentation, which I'm sure we will see coming out as themes in the relevant part of harm reduction in other countries. So I will not spend too long reflecting on that, just to hand over to Kern to speak about the Vietnam case. And over to you, Kern.
Let me.
I will try. I will start this my share.
Thank you.
Oh.
I think the thing that struck me in the case of Myanmar is how the harm reduction services managed to continue in light of the political situation. And this is something that maybe we can discuss during the panel discussion.
Okay.
Thanks, Karen. Over to you.
Okay. Thank you, Karen. Good morning, friends and colleagues. So it's my great honor to be here in a very exciting discussion and dialogue. Um, I think I'm very happy to share our little experience from Vietnam, and also very keen to learn from other countries, including from Philippines. So my presentation we will talk about what we have done. Of course, we will talk mainly about university, but also other local partners like Richard Health and also our civil society organization, and so the work with law enforcement with policymakers. So and also what we have learned so far and how we look forward to the future. Here is the the outlines of my presentation. So we talk about country situation and then what we have done and achieved and lessons learned and the future. So about the drug and HIV situation of Vietnam. So we have around 270 registered drug users. So it's registered under the government system. And major community of them, two-thirds are now living in the community, and the remaining are in prisons, in commissary, detention center, and other setting. And also amphetamines at other country in the region. So amphetamine high stimulants use is also the main drugs. Uh, Main type of drug use in Vietnam. However, heroin is still a very important part. The HIV, so we also have around 250,000 cases of infection, and we have also 10,000 more than 10,000 new infections every year. And also the HIV epidemic in Vietnam now is driven by people population, including people with the drug, ASM, and people sex worker. Uh, Now we move to the activities of the program.
So we have a C program together with other partners like District Health and civil society persons. So we implement diverse training and dialogue to build the capacity and progression of multi-sectoral uh, 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 response to drug and HIV because drug is very expensive issue including public health and other issues. So we provide training to see, our partner, key partner, civil society organization, community-led organizations, health sector, law enforcement, and also policymaker and legal experts, etc. Uh, Besides the training, we also organize several the program dialogue to improve the collaboration among the first of all the community and law enforcement, health and law enforcement, and also we also policymaker. We also work to promote evidence-based service model, for example, technical dose of methadone is recently we implemented in Vietnam. It is very successfully piloted. So together with other pilots of the harm reduction and drug treatment models. We also influence the policy making process to make sure that public health approach is well considered and evidence-based and approach also is incorporated in the drug policy making process. So we have training, we have sensitizations for the member of parliament, of national assembly, or key legal expert from the government. Uh, um, Here is we talk about some key achievement. So in Vietnam, we have a well-expanded video series program tied to the national government commitment, also the active involvement of the community civil society organization. So we have a well-expanded video series program in all the provinces of Vietnam. We also have well expanded opioid agonist treatment. So it's for people who inject drug like heroin or opioids. So it's now 15 years old, and now we have more than uh, 52,000 patients on the treatment. We also have patients on buprenorphine. So as also updated drug treatment option for methadone for people who could not join methadone. We also have some result and achievement regarding the impact of methadone. So you see the methadone also lead to reduction in hearing use and also other impact on also behavior of the people who inject drugs and also have first of all the stability of life, the decrease in legal violation and imprisonment, etc. So it's very it's official data from BBC Health. We also have national guideline for for harm reduction to for anti-diabetes stimulant use. I think it's in Vietnam the using of anti-diabetes stimulants. So we need to respond. So it's good that we should have we should have guideline to guide the service provision of treatment and harm reduction for people with stimulant. We also have harm reduction so guideline. So we have the treatment, drug treatment guideline, also harm reduction guideline. Two guidelines for the anti-gas bullets. Now some lesson learned. So first, imposing the use of anti-domestic lead to underrating importance of methadone program. So people now in Vietnam, so many misunderstanding that we should, for example, stop or downscale the methadone program because now no longer need for methadone because of imposing anti-capitalist miller. So it's not sure at all. And also, we found that the support of the government and law enforcement agency is crucial for security provision, the harvest provision, and right. We also have the issue of low scale of anti-capitalist treatment, and also enhancement lead to struggle in advocacy because whenever we want to advocacy possible for transform from compulsory detentions of the people who student to for the community by drug treatment. So we still have limited um, reliable data on service provision at community level because the low scale of the services. Also, it is more feasible to start with small scale of pilot service provision and for we scale up. I think it's for both government and private or CSO for civil society organization level. So, uh, what we look forward to the future. So in Vietnam, we will continue to institutionalization and scale up of take-home multi-day take-home goal of methanol. This is very important for us because people is very it's very important for people on methadone. They can they don't have to go to the methadone clinic every day. Is important for them. And also, the second objective for the future is expanding the treatment and medicine for people who use stimulants. It's very important. Of course, among us, we also focus on people who are on cancer because the population now is driving the HIV epidemics in Vietnam. We also strengthen and formalize a multi-sectoral collaboration partnership among community, healthcare, and law enforcement uh, to provide quality and private sector care for people who use drugs and, 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 and families. And that is also useful experience for Vietnam and are open for question and comment later on. Thank you.
Very much. That's very comprehensive and also interesting to see the advancements that Vietnam have made, not on rollouts of methadone, but also in responding to the emerging needs of people who use stimulant drugs. And we'll hear more about it during our discussion. But I'd like to move on to Indonesia to see what are they doing in their side of our region, particularly for people who are using people who are using drugs. Ali, we can see your screen. Okay. We want to put it into presenter mode. Yes, you can put your camera on. Great. The floor is yours.
Thank you, Karen. Good morning, everyone. It's a pleasure for me to be here with you in this very important dialogue and to be able to share Indonesia experience for compassion implementation of compassion program. I have only two slides as the committee informed me that we will only have like each of us like around 8 minutes. So just to give you a context about Indonesia, Indonesia is an archipelago country. It has more than 17,000 islands in Indonesia, with a population of 275 million people. 87% of the population are Muslim, and if you fly from the west part of Indonesia to the east part of Indonesia, it will take you 9 hours with another flight. So that's launched to Indonesia. And Indonesia, based on the report of 2022, Indonesian GDP is 4,783 US dollar. But before the program was started, I just wanted to share this with you. Back in 2000, Indonesia GDP is only 830 USD per year. So that's just to give you a little bit context. So allow me to share some milestone on the Indonesia harm reduction program. So when the first when the first AIDS cases was found in Bali back in 1997, the Ministry of Health then established a task force to monitor and report AIDS cases in Indonesia. But then until 1990, the government of Indonesia found that there are over 100 HIV cases found only in the year. And right after that, in the following year, President Indonesia issued President regulation to establish a national AIDS commission. You may see that there are and also one in 2006. I will get back to that. Now, when we talk about responsible use drug, starting in the mid of 90s, heroin was booming in Indonesia. It became the first drug of choice of people drugs. And it's easily found even in very remote. So it's really raised a concern for government of Indonesia and also practitioners and also civil society in the country. And then back in 1999, the support of the Australian government and also the US government, Indonesia conduct rapid assessment and response to make a new taking accusation situation in the country. And from that assessment, it is found that there was that Indonesia should start to implement the program as soon as. So one of the recommendations of this assessment is also to develop harm reduction working group at national level to discuss in more detail on strategies and respond toward this problem of the country. And also back in 1999, it was the first harm reduction program implemented. One in Bali and the other one by the local NGOs. At the time, we don't have any national official guideline on how to implement the harm reduction program. So it's still mostly depend from the support from the international NGOs to guide the implementation. Right after that, the harm reduction working group continue having series of consultation, dialogue with government official, with the local governments, so on. And in 23, we have the first methadone maintenance treatment program. One in Bali and the other one also in Jakarta. Starting from there, it was scaling up. In 24, Indonesia received grant from GFFDM Global Fund and also used the funding to scaling up the program from 2 provinces to more province to 8 provinces and more than 36 districts where the 100% program was being the first national estimation that Indonesia had was back in 2006. it was estimated that there was around 220,000 people who inject drug. But the HIV prevalence back then was about 52%. So one of two inject drug use was estimated HIV positive based on this estimation. So in that same year, Ministry of Health also issued the first national guideline on the implementation of reduction program. This include how to implement 12 activities that stated in the guideline, including outreach program, legal and theory, risk assessment, HIV treatment and care, and so on and so on. At the same year, the President of Indonesia also revised the previous regulation on national instruction. The current national, the 2006, the National Commission is under and report directly to the President of the Republic of Indonesia. And all line ministries also become a member of the National AIDS Commission. Under this regulation also mentioned that National AIDS Commission should be available at all provinces and relevant districts and cities in all over Indonesia to be able to have a coordinated response to these problems. And program progresses, and in 2015 there has been a shifting of drug use, trend of drug use in the country. Actually, until 2012 probably, heroin has become hard to be found in the country. But since 2015, amphetamine type stimulant is become the most common drug used in the countries. However, in 2016, the government, the president, decided to streamline or downsizing some government institutions or agencies. There are several government institutions or agencies or board was disbanded by the government of Indonesia. Mostly those who have cross-cutting function with the existing one. And unfortunately, National AIDS Commission was one of them. So in 2016, National AIDS Commission was disbanded by the government of Indonesia. With regard to the program implementation, Ministry of Health then become the leading agencies, but also expecting the coordinating minister and people welfare to lead, to take responsibility on the coordination response. The last estimate data that we have in 2019, it was estimated number of people who inject drug has been decreasing to 33,000, and the HIV prevalence is around 13.8% among people. So there are so much things that actually that I would like to discuss and share with you, but with the limited of time, I think it is relevant to share with you about the milestone of Indonesia on reduction to trigger further discussion. Some take-home messages that we can learn from this process is it is crucial to have leading agencies to coordinating strategies and respond on the implementation of harm reduction program in countries. um, because business no single agencies that can respond to this problem alone. It requires a multi-sector, but also it is important to work together with the civil society organization to have a meaningful involvement of civil society organization in the response. I give you an example. In the context of health services, in Indonesia, at a very low level, we have what we call a puskesmas or primary health care. This is services for public. They provide all different kinds of services. At least they have around 40 programs at the puskesmas level, from basic healthcare, nutrition, and so on and so on and so on. And the primary healthcare also then being asked to support the implementation of home reduction program, including the services. But again, the services, the service provider is sort of like a passive organization institution. And in a country where the environment is not yet supportive,
For example, in Vietnam, they've managed to have policies and programs that are in place that are addressing the emerging, changing trends. Unfortunately, for example, in Myanmar, the government stability right now does not really allow for huge amounts of scale up or implementation of a somewhat progressive drug policy that was enacted in 2018 and hasn't really taken off because it needs policies need people to push and drive them forward. And within the context of Indonesia, I mean, the clear message that came out of there from Ali's presentation was around coordination. Just to note that in all of these countries, criminalization of the use and possession of drugs remains. As Myanmar so these do not really make the situation of reaching out on harm reduction of pathways or compassionate pragmatism quite easy. but they can exist. And I think that's what we wanted to show with sharing examples from the region, is that we can still implement harm reduction programs, even if the right measures are not all in place and everything is not perfect in alignment with what we would recommend. And so with that, I want to just pause here and ask if there are any questions from the people who are sitting in the room. It's not perfect in alignment with what we would recommend. And so with that, I want to just pause here and ask if there are any questions.
Thank you, Karen, and thank you, our colleagues from the Southeast Asian. At this point, I'd like to start for question and answer. We have some minutes to read some of the questions. Perhaps, Karen, if I should start while some of our colleagues are thinking of their question. Um, I wanted to ask that question and emphasize on the point on how the national law benefit is restricted in a way for substance use. Different countries were able to implement public health interventions. And in particular, I wanted to ask from Myanmar, in the context of Myanmar and the difficult political conditions, and yet Myanmar was able to implement a lot of activities. Can you describe what did it take for you really implement this public health responses despite difficulties arising from political situation? With what
Sorry. Thank you. This is a very good question. Very difficult questions. Do you ever know that we first law to provide the policy and technical support to the national government, but in line with the support of the life-saving support for the most vulnerable population and humanitarian assistance, we continue our effort to support reduction in partnership with community civil society organizations. So now, CSO and policy leaders are really crucial for the continued implementation of the application of the evidence-based drug response measure. That's why with other evidence and innovation and developed interim HIV strategic plan during this period together with the other CSO, and then we will provide the benefits of all diversity building community and CSO and promote that and community this change and partnership with CSOs.
Thanks, Vilma. I just want to pick up on that theme of civil society organizations, because actually it was quite essential to all of the examples. You cannot implement programs for people who use drugs without involving drugs in the design of the programs, or else you will not reach the population. There are, of course, some services that governments can provide, and only solids would come out at the customers level, which I get would be at the local government level. It means, the health services that are there. But unless you have the civil society doing the outreach or the demand creation, we call it, for the services, you are not going to find clients accessing that. And so, especially in the context, like I said, the criminalization is still there, the criminalization for drug use is still there. So if you want to really reach the population from a public health perspective, from a professional perspective, we have to find ways around how to reach that population. And that's where it's going to be really essential to involve civil society in the outreach.
Are there any questions or inputs from our participants? COP races.
As usual, when it's about asking a question, hi, Dr. Wilma. Just wanted to complete my answer because I think out of audio, she mostly answered on how do we continue services in the current context of Myanmar. But as happened to us somehow before Myanmar. Now, despite the legislative framework that is not conducive and the services being started, scaled up, and benefit institutional policy framework. Well, one of the elements is the element that currently is highlighted, important solving the civil society problems. The second element is multi-sectoral approach to build the United Nations all the time, so it almost sounds an anti-word. No, multi-sectorial on the part so enforcement, it's judiciary, means social welfare, employment, etc. And this in Myanmar, the fact that all those people were involved in those initially small pilots made moving this to the legal and policy level easier down the line. And also, because our colleagues in Myanmar are always very humble on their achievement. But going now, and I agree that there was still 33% of prevalence among people with injectors. That is correct and that is to be addressed. But when I arrived in 2000, around Mitina, State, the prevalence was 60%. So we did not stop the harm, but the harm has been reduced. And just to echo with the situation, the prevalence in several areas of the projectors is close to the level that we found in Myanmar in 2000. So let's be compassionate.
Thank you very much.
Thank you, Arvind. Thank you.
I have a question, and maybe Paul or Ollie can answer your question. When we implemented public health responses such as needle syringe program, how did the community, how did it affect or change the lives of people involved in trips? So maybe we could start with Paul.
I think thank you very much. This is very good question. In Vietnam, I think we quite the same issue. Like other country is a stigma and discrimination towards the people with drug. And when we implement the WHO in before the 2010, around 2008, the 9, when we implement that, so we will receive the question. Are you going to support the drug use? Or are you going to legalize drug use? So I think this is always a question. Even the question from government, people show or the not only the committee from government officer. So I think the question is our question is that if we don't support we don't mix like the season is was with the legal city program. So it's evidence based, it's evidence program, and also in last situations, no present that make the use situation worse. However, we try to focus on public health impact of drug use and try to address this because to make sure that the people who use drug and have access to legal experience. So like Mr. Olivier said, it's harm reduction. So we try to reduce it and to make sure that the people who use drug can control use of drug and also can control the harm over to Olive. It's from Eagles.
Question. I think what people understand as well, harm reduction is not only about influencing. There are more than it's into education, into personal, okay. Uh, yes, there was a challenge also implementation of SEA. Yeah. But it is not only to PhD, it's also to prevent possible, as Rome just mentioned. So with regard, I'm just going to the line with regard to the line enforcement, is this harm reduction at the national level, at the national level, is really taking the role of these responses of academic representative, society, and so on. And the advocacy work lead by the Compassionate Rights Commission finally managed to agree on National Rights Commission and one national agencies. The legal series that the outreach worker who did the legal series will be arrested. For people who reject the series without the substance itself, be arrested. There was an end of the National Rights Commission and national agencies. And again, also, an education is required in community. For instance, in one specific area, there was an NGO who also donate or support for human services, including series. In Indonesian regulation, there are three types on how to distribute influencer. One is static, which is in the Puskesmas or in drop-in center. One is satellite. Satellite means the area which was managed by peer in the area, and the third one is mobile. Mobile is the outreach worker will to the hotspot. Um, before the implementation, it's important for the NGO, the outreach worker, and also harm reduction of the stakeholder to communicate with the local stakeholder, inform them, introduce them. This is our organization. We are going to, and also educate them about what is exactly and so on and so on and so on. So they all understand about what this organization doing, what these people doing, and to deal with the, the youth leader, in the program also design, we also design a cleaning day. So like 2 or 3 times a week, an outreach worker together with the educator, they will go around where is the hotspot collect and also uh, uh, that is what the collecting they used to do. And additionally, they also get to being a governance, they are disengagement to the courts. Okay, further by the office worker or hundred as practices. First, to ask people use drug, not use drug. Second, if they are using drug, please don't inject drug. Third, if you inject the drug, please use new needle. Fourth, if you don't have a needle, please clean the needle. So needle is really the end of the process of the education to the community and also the law enforcement. So on top of that, there is also a series of sessions. For instance, I mentioned to you about risk assessment. In the program, sign what we call individual risk assessment and also a group risk assessment. How do we educate people to understand that it's sharing legal that before that they can accept risk to be a risk that they cannot take anymore. So before they said okay, they're okay to share legal, but then through the education, the objective is for them to have the perspective that it is not okay to school anymore. There are individualized assessment, but there is also a group-based assessment. Yes. Because they will mostly will use together with that group. So it is important also to take them. I think it's that.
Thanks, Oli. Thanks, Oli. I just want to bring out some final points and some final observations from all of the presentations and discussions today. Firstly, is that as you can tell, implementing a harm reduction program requires a large amount of coordination. Services that are being provided are responsive to the needs of the population that they are intending to serve. You mentioned the legal and solution program lead, and as Ani mentioned, and I was nodding there, he said that we always like to talk about harm reduction and end at legal and solution distribution. Actually, harm reduction is way more than that. There are legal services, social welfare services, all of these form part of drugs, right? And so ultimately, we need to not just look within one lens of the services and the coordination and the range of interventions that need to be coordinated with the harm reduction approach. Lastly, just to say that yes, we understand there are challenges in this region. There are a lot of challenges in this region, but it's also not the only place in the world that has these challenges. We just come back from the harm reduction in Australia, and I visited an injection site where they do medically supervised injection facilities there. And even within that facility, the community people are challenging whether it is an effective approach in that context. So it's really important if you start running harm reduction interventions to make sure that there is a benefit for the community, that people can see the positive outcomes as well as keeping the interventions in line with what the intent of it is. It's going to be very difficult because we all, in every community in this region, we are facing stigma and discrimination of people who are using drugs. And that perpetuates the punitive laws. But again, making this to be an approach to addressing people's approach to how they perceive drug use and drug dependence within the context of a society that we're trying to get towards helping address the situation, not just turning our backs on what they consider is moralistic, useful, and what they consider is in opposition to their views. So, yeah, it's a pragmatic approach, and I love this terminology that you decided on of compassionate pragmatism because that is essentially what reduction is, and I really hope that we can have more of these discussions around two things for the countries who are because there's the challenge that our colleagues are facing, having to convince governments that these programs are effective and essential in the challenge of prevention of communicable disease spreading. Thank you. That's what we have to share with you today. Over to you, Lee.
Thank you so much, Karen, Paul, Whitmore, and Lee. We're very grateful that you joined us. Let's please give our panelists a round of applause. So at this point, we'll have a break. Let's have a 10-minute break. There's coffee and snacks served. We will resume in 10:50. Thank you very much.
a clinical social worker who has worked in homeless services for 35 years. She has developed programs and services for people with co-occurring disorders, including street-based counseling centers. She co-founded the Harm Reduction Therapy Center and served as its executive director for 22 years. Together, they have trained thousands of mental health, medical, and social service providers in their treatment model, and including internationally. They have written many
articles and 2 books on this model of treatment, which I highly recommend. Practicing harm reduction psychotherapy, which is for professionals to learn about the model. And the other one is Over the Influence, which is more for the general public and for clients. Both of these books have been translated into Chinese, and Over the Influence was recently translated into Chinese.
They have maintained long-term consultation relationships as a clinical expert in at least 30 social service, housing, and mental health organizations in the United States.
And they have also intensively trained and supervised 100 mental health professionals working at their center. And so, I've known Dr. Pat is for like more than 10 years. So I often also say this with all confidence that on top of all these incredible credentials and vast experience, we have with us also two of the kindest and most generous individuals
I've ever met.
And
they also exemplify how compassion and pragmatism are not just approaches to substance use concerns, but also really a way of life. So please everyone, join me in welcoming Dr. Pagmati and Miss Julie. Thank you.
Thank you so much. It feels like we've known each other for many more years than that. Hello everyone, I'm really honored to be here among my fellow drug users. As I look out over the tables, I see many cups that I think contain a warm liquid drug that will hopefully keep you all alert and interested over this next period of time. That's the beginning of compassion. Is understanding that there is no us and them. There are not those drug users. We are drug users. In public health, we've been using principles and terms like compassionate pragmatism for years. Public health puts solving the problems of diseases ahead of any moral stance about those diseases, or against the people who have them, or the ways those diseases get transmitted. Public health is at its heart pragmatism in action. However, we have never used these words, compassion and pragmatism, or these guiding principles when talking about and when creating services for people who use drugs. Compassionate pragmatism was built on the voices of people who needed services. During the HIV epidemic, it was patients who were dying who demanded more attention and faster action from the public system. They formed a group like ACT UP to press their message. And what happened? They disrupted meetings of the Centers for Disease Control, demanding that research be fast-tracked and that experimental treatments be allowed to be used immediately in order to save their lives. In the Netherlands, during the outbreak of hepatitis B among intravenous drug users, it was those drug users who demanded treatment. They formed a group called the Junkie to press their. And what happened? They demanded and got mobile medical vans that would come into their neighborhoods to deliver important services like access care and give them access to nutrition. In a northern county of England, a doctor who listened to what his patients said they needed had been quietly treating opioid patients for years and saw the looming disaster of HIV in his drug for 60%. He took his work to the next level and along with nurses, social workers, outreach workers, and the police, formed a center that in 4 years eliminated both HIV transmission and the sale of active drug users, the people most affected by problems, alongside medical and social services who cared deeply about them, formed what they called the Harm Reduction Movement. Now, we've heard worldwide to save the lives and improve the health. People who use drugs have, since the 1970s, have made a clear stated demand of us. Those of us who are policymakers, those of us who, and what they say is nothing about us without us. The inclusion of active drug users is not just an option. It's important for us to remember that these are the people who began what we are now following. Term harm reduction. Yeah. It's been debated and applied from top levels of government to the person on the street who just wants us to get rid of drugs. And one person who very early on saw this controversy about the term harm reduction and saw it as damaging a project for progress in the treatment of these drugs was Dr. Alan Marlatt, an internationally recognized researcher in alcohol and abuse. In his writings and talks, he explains to the world that harm reduction was born of principles of compassion and pragmatism. He was the one that gave us those words, that language to use. The use of these words brought down the temperature of the debate to the point where those of us who liked programs of reduction and those of us who didn't could begin to work together to better take care of drugs. Today, among the many problems that drug experience, we have an overdose crisis that is calling on all of us to take a step away from our personal and moral feelings about drugs, drug use, and harm reduction, so that we can quickly adopt programs and interventions that will stop incredible damage occurring to drugs and the damage that it sends to their families and their communities. What often gets lost, and a reminder, in creating language that's more accessible, memory of these origins of the public health interventions is important. That these interventions were demanded by and initiated by and with the wisdom of people. So I'm a psychologist and a psychotherapist. I was one of those professionals who, early on in the HIV epidemic, recognized the need for compassion. I was the director of the mental health team that was part of the health clinic that served primarily gay men in San Francisco. I was a witness to the early days when young men got sick and died within a week. When health professionals were so terrified that many of them refused to touch their patients. And when families across the United States sent their sick sons to San Francisco to die. As hundreds of our patients and dozens of our staff died around us. We saw a dramatic increase in drug use among men who never really used drugs before. As the director, I was responsible for sending these young men away from mental health and into our segregated drug treatments, into rehab, where they were told that they had an incurable disease, drug addiction. They couldn't be trusted because they were addicts and liars. They had to stop using all drugs right now or face jail, institution. The treatment programs used methods like attack therapy groups. When these young men came back and told me what was happening in these drug treatment programs, I was horrified as a professional and angry as a human being. I decided to never again take a referral to a drug treatment program like this. Now, the United States has this unfounded belief in the necessity and the effectiveness of rehab. Families believe that you can send a person to rehab and then a month or 6 months later, it went to hold America with 28 kids. And of course, that's not what happens. But when you think about it, it makes sense that rehab mostly does not work. Because these programs rarely use any of the evidence-based practices that help ensure lasting change. And they focus solely on abstinence from drugs without any attention of that drug. So what you get is short-term change, followed by relapse, and an evolving through of treatment, drug use, back to treatment. The belief is that, like AA, the program will work. And so our system blames patients for failures, rather than examines the great programs that result in. So in this environment, and with these feelings, starting in 1983, I began a journey to research, discover, and basically make up, when I had to, clinical best practices to work with people who are misusing drugs. From that time on, I was joined by many others, including Dr. Ellen Marlatt, to develop what I called addiction treatment alternatives and what became known as harm reduction psychotherapy, built on the twin foundations of we're aware that the terms compassionate pragmatism are general words that can refer to any number. So it's important for us to be very specific about what we mean by these words, so that we hold ourselves accountable to the principles and practices as we develop programs for people who return. Jeannie and I are going to introduce you to what we think of as the core values of compassionate pragmatism. This morning we'll focus on the components of compassion, and in the afternoon on one of the most important elements of pragmatism. We've identified 4 components of compassion that guide the creation of services. These components are compassion, connection, and care. And as we talk about these 4 commitment, compassion, connection, and care, it is our hope that we communicate that these are our values, not just our intellectual values, but also what we deeply believe and care about. commitment. We make commitments. We work very hard to be willing and able to approach people who use drugs without judgment. We practice respect for the relationship that a person has with their drugs, which means truly respecting the experience, the perspective, and the wisdom of our clients.
We strive for partnership, which means to work with, not power over our clients. And again, believing in what drug users have told us over the years, nothing
about us without us. We have a commitment to making use of evidence-based practices and to set aside morally based belief systems that restrict rather than expand our understanding of how the best help people. And lastly, we firmly commit to ending coercion and punishment as the main tools for eliminating the harms of drugs. What does it work? What does it mean to work to become able? In order to keep these commitments, we also have to commit to struggle with our own ideas, beliefs, and attitudes about drugs. We have to struggle with our personal and family experiences. We have to commit to separating our personal preferences and choices from our responsibilities as helping professionals and as leaders. This is the very difficult and necessary personal work that we have to do in order to be respectful and non-judgmental for our patients and clients. It is difficult work, and it requires institutional support. Jeannie will now talk about compassion, protection, and care. Thank you.
I think this is an extra mic for commenting. I think this is an extra mic for you for commenting.
Can I actually comment while you're talking?
You can comment. Is this about the right distance? Thank you so much. As you know, today is us talking about principles and a lot of information, which for me has felt somewhat overwhelming so far. And what I'm going to do is bring us closer to the people that we're talking about, the people that we're concerned about. Before I do that, I want to assure you that no matter how much we say that production has to be an intersectional approach between institutions and governments and civil service organizations and individuals and people who use drugs, it doesn't matter when all of those organizations and people collaborate. It actually doesn't. If every single person in this room either already does or will walk out at the end of this week practicing harm reduction. And you can do it without telling anybody you're doing it. You can do it in secret because harm reduction is not just about a set of strategies, some of which are very controversial and people hate them. Harm reduction is also about a way of treating people. A way of treating people that we find complicated, that we have in ourselves, that we like, that we don't like, whether in our families or in our community members, that we feel deeply disturbed about, and how we embrace and treat those people is the first challenge of practicing harm reduction that we all do it, or we all live with it by the end of the week, no matter what anybody else says. Okay? So that's a little rant to start things off. I met my first crack smoking people at a homeless shelter in New York City in 1990. I was a social work student and I was already in my early 30s and I'd been working with families and kids for about 10 years before that. The shelter housed 200 women who were diagnosed with serious mental illness. There were so many people experiencing homelessness and so many shelters in New York that the shelter system could actually rely on people on that time. Homelessness exploded in the previous 10 years in New York, primarily due to dramatically increased poverty and gentrification in cities. Crack cocaine had been introduced into inner cities as a cheaper alternative to cocaine, which had been very popular amongst middle class and upper class people in the United States. Many of the women that I met had been former inmates at long-term psychiatric hospitals that had been closed in the 1960s, 70s, and 80s. They were homeless primarily because they were poor, and because they had long since lost the families who should have been cared for them, and because the new community health system in the United States had not been funded enough and had not developed the infrastructure to provide support outside of medications that these folks would need. I had no preconceived ideas about drugs. I didn't have a whole lot of experience with drugs, and I knew almost nothing about mental illness. My job was to get as many women as possible to accept medical care and shelter clinic, especially gynecological care and cancer screening, and also to accept psychiatric medication, which usually meant the old school antipsychotic medication called Haldol, ones that suppress your dopamine and make you feel half dead. What I learned from my clients was how terrified these women were. They truly believed that the doctors in the clinic would hurt them. They had probably been very badly hurt in the past. I learned how cocaine is an antidote to psychiatric medications. It stimulates dopamine, makes you feel good. So why would we not prescribe it, especially if you were taking antipsychotic medication? I also learned that drugs don't say what was too scary to say. Like when my client Sarah was able to explain to me only after she had drunk 2 mini bottles of Bailey's Irish cream that the nuns at the ladies' shelter had cut out her heart and replaced it with a plastic heart, and that's why she lost her bottle. What she was actually trying to explain to me is what it was like to have her first heart break. I also learned that psychiatric symptoms themselves can be comforting and empowering. Like my client Lorena, who believed she was screaming on street corners every day, that she was still a teacher and she was lecturing to her students. She had actually been a teacher before she had her psychiatric break. Why was she not those wonderful hallucinations? I also learned that coercion can destroy a relationship. My supervisor said to me, "Here's a trust student now. She has never talked to anyone else since I worked at this shelter. Why don't you tell her that she can only come on our field trip if she agrees to take medication?" I didn't like the idea, but I did. Here's her never talked to anyone. And why would she? My first job in substance use treatment was at a hospital detox and stabilization program at the Department of Medical Affairs in San Francisco. This was truly a dual diagnosis program at a time when they almost didn't exist in the United States. Psychiatric side of the treatment was excellent, but the language of the drug counseling was insulting and shaming. The staff would say things like, and these are also things that are very often at Alcoholics Anonymous meetings in the United States. They would say things like, "Your stinking thinking got you here, so why don't you stop thinking and just follow the program?" Or, "Keep it simple, stupid." It's a very popular saying. Yes, keep it simple, stupid. And addicts are all liars. They just can't be trusted, so don't listen to what they say. This was disrespectful and even some reselling of verbal abuse. In the group that I facilitated every day, I heard patients talk about their feelings of shame, disappointment, of hope, and of fear. I learned that they did not need to be told what to do. They were free to bring it out. All I needed to do was to create a space for them to hear their own thoughts and to speak their true words. This is where I learned about compassion. So compassion is the first core value of compassionate pragmatism. And it means, first and foremost, dealing with suffering of all beings, including people who use drugs. It means understanding why people use drugs and why some people get in trouble. At the beginning, drug use happens as an opportunity, as an accident, usually when we're very young. And in context, it was usually about fun. If it continues, it's usually about continuing to seek pleasure, or it's about medicating pain, or maybe it's to change one's perspective. If the reason someone is using drugs is not obvious, then we try to find out. What does meth do to you, for example? How is it helping you? What do you like it? If a person is so deep into drugs and the problems caused by their use are so big that neither they nor we can see why they use, then we ask, tell me how you got started. What did you feel at the beginning? These are all strategies for us to begin to understand the person's relationship with drugs and to feel compassion for it. During my time in the hospital program, I committed myself to creating programs that would give people space and the support to understand themselves and to find their own path of change. From the hospital, I went to a drop-in center and developed a group for people with active substance use. I called it the Sobriety Support Group, and I quickly explained that it was a group for anyone who has a relationship with drugs and has other problems. I said, you do not have to be clean sober to come to this group. People came in very large numbers. Many of them intoxicated a wide variety of drugs. Many of them abstinent and both participating in self-step outpatient programs or residential programs. People that even get permission to leave their residential program up to this group, which came to be known later as a harm reduction group, from their very conservative abstinence-only programs. They had no idea that they were getting their clients out to come and visit. And some of the folks in the group were actively psychotic, participating in successfully discussion, sitting in the corner and sleeping. This was my first harm reduction program. I had never heard the word harm reduction before. I did wonder how the group would work, because I had never done such a thing before. It was my own beginning of learning something called practice-based evidence, which is a little different than evidence-based practice, and it's something that I'm going to talk more about tomorrow. People came to the group, which met 3 and then eventually 4 times a week. They came in large numbers, and sometimes it was standing room only. People would come and go to make space for each other and to take breaks if they were too many students. After a few months, I started hearing various members say, I was on my way up here from the shelter. I was going to stop and get a gift from my dealer. Then I thought about the group, and I thought, well, why don't we just go to the group, check out what people are talking about, and get a cup of coffee. I can always go use later. That, to me, defined the first evidence of success and change. Is people pause it, think twice before going to get a gift. And what it meant was that the people were accepting the group into their lives and letting us sit beside them with their drugs and with all of the other things that were helping them. That is the beginning of compassionate pragmatism. Sitting beside people no matter what they're doing, no matter how we feel, until they let us sit beside them. I learned that development of connection is the most important first thing to focus on in our work. That if we develop a relationship with someone, not what they're so using, we have a chance to help them change before further harm is done. So connection is our next core boundary. Harm reduction and compassionate pragmatism put the relationship with the client working in us. Why is this? In psychotherapy research, and in all the research on motivational interviewing, which is probably the most heavily studied of all counseling approaches, and in research on self-determination, which we'll talk about more about, it is the relationship that makes the most difference or the most change. As people who practice compassionate pragmatism, we are welcoming, kind, and caring of everyone, no matter how complicated or how challenging. We practice what Maya Angelou, one of the most well-known and well-loved poets in the United States, said, "People don't remember what you said, but they do remember how you made them feel." We do not wait for people to get by. Very popular idea in the United States. People die at the bottom. People contract HIV and hepatitis at the bottom. Or they just sit there, dying more slowly and suffering greatly. Instead, compassionate pragmatism asks us to join the person wherever they are and walk beside them on whatever path they're on. At some point, they will learn to trust that we are there to help them, not to harm them. We do not tell people what to do, and we do not force people. Not only does coercion not work, it is not even necessary. As happened in my group, people will voluntarily and willingly just listen to a group or three once they have taken us in their minds and their hearts. And we believe, as Johann Hari said, that the opposite of addiction is not sobriety, it is connection. And with that, we're going to see a short video, which has lots of knowledge. Some of you might see this video. I've seen it hundreds of times, and so love it.
This is a very stupid question, right? It's obvious, we all know it. Heroin causes heroin addiction. Here's how it works. If you use heroin for 20 days, by day 21, your body will physically crave the drug ferociously because there are chemical hooks in the drug. That's what addiction means. But there's a catch. Almost everything we think we know about addiction is wrong. If you, for example, break your hip, you'll be taken to a hospital and you'll be given loads of diamorphine for weeks or even months. Diamorphine is heroin. It's in fact much stronger heroin than any addict can get on the street because it's not contaminated by all the stuff drug dealers dilute it with. There are people near you being given loads of deluxe heroin in hospitals right now. So at least some of them should become addicts. But this has been closely studied. It doesn't happen. Your grandmother wasn't turned into a junkie by her hip replacement. Why is that? Our current theory of addiction comes in part from a series of experiments that were carried out earlier in the 20th century. The experiment is simple. You take a rat and put it in a cage with two more bottles. One is just water, the other is water mixed with heroin and cocaine. Almost every time you run this experiment, the rat will become obsessed with the drugged water and keep coming back for more and more until it kills itself. But in the 1970s, Bruce Alexander, a professor of psychology, noticed something odd about this experiment. The rat is put in the cage all alone. It has nothing to do but take the drugs. What would happen, he wondered, if we tried this differently? So he built Rat Park, which is basically heaven for rats. It's a lush cage where the rats would have colored balls, tunnels to scamper down, plenty of friends to play with, and they could have loads of sex. Everything a rat about town could want. and they would have the drugged water and the normal water bottles. But here's the fascinating thing. In Rat Park, rats hardly ever use the drugged water. None of them ever use it compulsively. None of them ever overdose. But maybe this is a quirk of rats, right? Well, helpfully, there was a human experiment along the same lines, the Vietnam War. 20% of American troops in Vietnam were using a lot of heroin. People back home were really panicked because they thought there would be hundreds of thousands of junkies on the streets of the United States when the war was over. But a study followed the soldiers home and found something striking. They didn't go to rehab. They didn't even go into withdrawal. 95% of them just stopped after they got home. If you believe the old theory of addiction, that makes no sense. But if you believe Professor Alexander's theory, it makes perfect sense. Because if you're put into a horrific jungle in a foreign country where you don't want to be, then you could be forced to kill or die at any moment. Doing heroin is a great way to spend your time. But if you go back to your nice home with your friends and your family, it's the equivalent of being taken out of that first cage and put into a human rat park. It's not the chemicals, it's your cage. We need to think about addiction differently. Human beings have an innate need to bond and connect. When we are happy and healthy, we will bond with the people around us. But when we can't, because we're traumatized, isolated, or beaten down by life, we'll bond with something that gives us some sense of relief. It might be endlessly checking a smartphone, it might be pornography, video games, Reddit, gambling, or it might be cocaine. But we will bond with something, because that is our human nature. The path out of unhealthy bonds is to form healthy bonds, to be connected to people you want to be present with. Addiction is just one symptom of the crisis of disconnection that's happening all around us. We all feel it. Since the 1950s, the average number of close friends in America has been steadily declining. At the same time, the amount of floor space in their homes has been steadily increasing. To choose floor space over friends, to choose stuff over connection. The war on drugs we've been fighting for almost a century now has made everything worse. Instead of helping people heal and getting their life together, we have cast them out from society. We have made it harder for them to get jobs and become stable. We take benefits and support away from them if we catch them with drugs. We throw them in prison cells, which are literally cages. We put people who are not well in a situation that makes them feel worse and hate them for not recovering. For too long, we've talked only about individual recovery from addiction, but we need now to talk about social recovery, because something has gone wrong with us as a group. We have to build a society that looks a lot more like Rat Park and a lot less like those isolated cages. We are going to have to change the unnatural way we live and rediscover each other. The opposite of addiction is not sobriety. The opposite of addiction is connection.
You know, the context for this film, you can see it again, is the United States, which I think is quite different from the Philippines. I think that the culture as a society plays much difficulty with connection as we seem to be in the United States. Even though this is a years ago. I also think, speaking of this is comparing some of my earlier remarks, that the way that people talk to each other, certainly don't know that happens here, but historically, the kind of language and the kind of insults and the kind of yelling and screaming, really, that's historically happened in U.S. drug treatment programs, it's hard to imagine. My experience of Filipinas, both in the United States and here, is that people are very kind and very polite. So I think things are different here. Nevertheless, even if there isn't the kind of distancing, isolation, and seeking after stuff here, particularly in the United States, there still is the phenomenon of segregating and stigmatizing people who do drugs. That seems to be a group of people that we don't feel that we have to, because we think that the behavior of using drugs is willingly chosen. We seem to feel that it's okay to exclude, isolate, stigmatize, and punish. So, while a lot of the values I was saying,
we can apply to all kinds of things. It's not easy to apply those principles to people who use drugs because of how we feel about drugs and how we feel about the behavior.
Store up your comments. We're going to have a few minutes, I think, for questions. I want to say one other piece about the last principle of compassion, which is care, and how we think about care. But the model of care that we're talking about is radically different from traditional substance use treatment, and radically different from all professional treatment that places a professional in the role of an expert who diagnoses the patient and prescribes a solution. Our model of care is a true collaboration between experts, and we center various people who use drugs in the context of what we're talking about here this week. All of what we've said so far speaks to a system of care that is based on public health principles. I said earlier, public health puts solving the problems of diseases ahead of any moral stance about those diseases, about the people who have them, or about the ways that those diseases get transmitted. Public health programs do whatever it takes to reach people who are ill or who are vulnerable in order to treat or eradicate again, public health is practice in action. So, care for people who use drugs includes a few things. Just talking about a few things today. There are a lot of things we're talking about the rest of the week. Prevention of drug misuse. First of all, means giving young people honest and accurate information about drugs. We cannot keep lying to young people about what drugs do. This is what we are often telling them is not true. Public health means treating people who use drugs as you would treat anyone else, including them without conditions in all of our medical and mental health care systems and plans. As who said this, one of the people speaking earlier this morning talked about substance use disorders being mental health disorders. They are. They're in the Diagnostic and Statistical Manual of Mental Disorders, and it is the only diagnosis in the DSM where the sufferer has to quit their symptoms before becoming eligible for harm prevention and minimization, which are other words for harm reduction, means giving people who persistently use or misuse drugs the tools to stay safer and healthier, so that they can also stay alive and feel more motivated to change their relationship with drugs in the future. And treatment for people who misuse drugs is needs to be evidence-based, integrated, client-centered, and partnership. Lots of concepts that we're going to break down for the rest of the week. Finally, care must be grounded in humility. People have many resources, even if we don't think that all of their resources are healthy, including especially their drugs. What we have found is that people dose themselves with care, that they dose themselves with treatment, just as they dose themselves with drugs. If we truly mean to walk alongside them, we need to listen to what Mr. pointed out, that healthcare is actually a small part of our health. There are many other social determinants of health. So we need to make sure that we don't overly center ourselves in the center of someone's health. What this means is that as healthcare providers, we don't need to know when to move forward our actions of compliance, when to direct them, when to support them, and when to step back and make patiently until they're ready. All I have to share right now. Please, shall we take questions and comments, get some discussion going?
Thank you very much, Jeannie, for very inspiring and very moving keynote presentations. At this point, I'd like to invite our participants to give their thoughts or questions to our keynote speakers. So Pat and Jeannie will be with us today and for the rest of the week for our workshop participants as well, so we can have a deeper understanding of compassionate pragmatism. But now I'll open the floor for comments or questions. We have distributed some of the mics there.
I request to introduce yourself, the organization, and if you have a question. Go ahead.
Hi. I'm Jude from the Department of Health, the Department of Health. Just ask, how did you sensitize the law enforcement agencies when it comes to harm reduction, since I think that's one sensitive issue here in the Philippines when it comes to term harm reduction.
How do you make the law enforcement easy for other drug policy harm reduction? Your experience.
So Jude was asking, law enforcement groups are really important stakeholders in pushing for harm reduction. But the issue is there are sensitivities, bit of resistance on harm reduction from law enforcement, but even some of our organizations. So Jude was asking, any strategies that you can recommend on how to approach law enforcement?
Yes, in the United States, law enforcement professionals who believed that we needed a different approach, that we needed harm reduction, formed their own advocacy groups. And one of them was called LEAP, Law Enforcement Against Prohibition. And these were police officers, primarily police officers, who banded together to create a dialogue about why coercion and why punishment and why the over-involvement of police in drug users' lives is counterproductive. So I think that's a strategy, is to begin with the law enforcement professionals who are already on our side.
I'll say a couple of other things too. Center in England response to the HIV crisis. The professionals who were setting up this center, which was phenomenally comprehensive, they were but they approached the police proactively, said, look, we need to take a health approach to stopping HIV, a huge vector of disease. Laid it out. And they said, if you will stop arresting people who you catch with drugs to the center, we'll take care of it. So what the police did is they were the word in England. They would cite them, and then they would send them over to the center. And what was amazing, said earlier, is they eliminated, found that actually no street drug in this county. Because one of the programs center opioid substitution assisted treatment.
So they were giving people methadone. They didn't have They were also prescribing morphine or heroin, which is something that actually Switzerland. So, and people were using quite perspective. The program was successful. Now, there are a lot of us who just shake their heads and think it's ridiculous to us. Said, find those folks who but we have had a all-out war in San Francisco right into another decade of on the streets, and so we're going through last week major, but it's not going to work. So.
Yeah, and I wanted to mention, actually, that's a very good point to mention, that there's a good space for collaboration with law enforcement. And in this room, we have law enforcement representatives from the police sector, from the Philippine Drug Enforcement Agency. And I think one opportunity is to really find that collaborative space between the health sector and justice sector and the law enforcement. Because for the longest time, when we talk about addressing drug issues, different sectors are moving their own business without much discussion and collaboration. And I think this is an important time for us to try to find how do we merge those efforts and approaches. In the organization, in the joint program, we always say actually that we have good public health, we have good public security. Because if we make people healthy, if we make our communities have good indicators for social determinants to health, that is basically addressing homelessness, that is addressing unemployment, that is addressing issues of insecurity. So I think I agree with that a lot. This is for collaboration, especially since in this joint space that we have right now, that these individuals who are looking at the same direction. And I think the Philippine government as well made a commitment now to moving to more public health approaches and maybe tempering some of the law enforcement activities. So that's a good conversation.
They like to be out.
Yeah.
They really do.
That's good. Yes.
My name is Molly. Center Student, and I wanted to back on like that bringing the folks together so it's a fun person here. And it doesn't just need to happen at the national level, it can really happen at the. So I was involved, we have a very large HIV, so protection programs that happen small part of our country. And I got to attend these meetings where you have the mayor and the chief of police and some of the people who were using drugs and doctor, and they were all meeting together in their office. Conversations were coming up where law enforcement would say, what do we do? Service program here, and now we don't know what people are going through. If we should arrest them because that's what our law, like that's what our job is, and so then come solutions together. And here's a plastic card that people carry, and making it clear that if you have the syringes and works, we won't arrest you, but if you have a drug in that, will, and just sort of laying it all out. But I think those conversations are where it starts. I just want to really make it they can happen at the local level, at the small level, not just these large conversations.
Very much.
And I'm going to add a word of caution because those of us who are working toward collaborations are generally not those of us who have been victimized by law enforcement. And so it is essential to have people with lived experience, people who use drugs,
heavily present at these attempts of collaboration because they bring the experience that we don't have. And we tend to not understand why people who use drugs don't want to have anything to do with us if we're collaborating with law enforcement. So it's a delicate walk that we have to do. But we're not the ones who've been at the mercy of law enforcement. So we don't know what it's like.
Thank you very much. Any other comments or questions from the audience? Just like also to participants said about it. It's been a challenge also. I'm from Cebu City, originally. We're working with PILOTs on the community-based rehabilitation program. Now, as Kaki mentioned a while ago, nothing for us if not this, right? So it's been a challenge also in the side of the LGUs because before our treatment, the community-based rehab treatment, they're actually based from a list from our law enforcement agency. So you also mentioned about that when care is needed, it should be done right. It shouldn't be coerced or something. However, it's somehow kind of coerced because they are asked to surrender in writing. But they can undergo the treatment with us. So my point is, since even they are still not even in contemplation stage, there are also changes that they are now supposed to do so. But in one way that we're trying to bridge that gap with nothing for us and not with us. What we did is for our facilitators and for our women conducting debates, we actually asked for the community rehabilitation network really empowering POs to do that. Because when we started, they had doubts. Because if we do that, they will not trust us because we haven't been in their shoes. But when we did ask the help and the assistance of those who were recovering, the program seemed to be good. However, since it could be relaxing and the sustainability to we're banking on the Compassionate Pragmatism on how and and monitor the current program. So hopefully in the next few days we'll be able to do that. Thank you so much. Thank you very much. You have any comments?
Yeah, I was just reading some recent research on coercion, and what they seem to say is that if a person is coerced into anything, but they're studying treatment, that if the person comes to believe that this is what they want and this is what is good for them, then they will be as successful in treatment as the person who came voluntarily. And so what that means is that even with people who are coerced, our first job is to invite them to explore their life, invite them to see whether or not there's anything that might be helpful to them, so that they decide, this is what I want.
I'll just piggyback. Let's keep talking about this week because we had a lot of experience, not that volunteered to potentially teach their remaining all the time. So we had a lot of strategy. Experiment.
Thank you. Any other? I see Delosh, Jonah, and then Van, and Marjorie. Let me just manage the time. It's 11:57. I realize we have time for two. I will privilege Jonah because I know Jonah will join us for the rest. The band will be here. RJ will be here. So that means Jonah and Milosh will be given that last piece of. Jonah, please.
Sure. There was a time in Europe where we had a shelters were open and sector specific to mention that some of the facilities were already just curious if there was any research that find out what were the primary driving limited maybe what were their existing challenges or in the facilities or in the program itself or if ever would have been responsive programs or services address these distinct issues.
Sorry for the confusion. I was referring to homeless shelters. So these were not. That's okay. Same good question. No formal research that I know of. At the time that I was there, the whole concept of mental health substance use disorder brand new. Like the first papers have just been published. And the dominant, so there was not quantitative research, but the dominant theory of self-medication. I think our general principle would be work with people. Our general principle of drugs is to assume that there's some sort of issue, like circumstance, moral sort of trauma history, something. So we sensitively look for to get something. And it is statistically co-occurring disorder not the exception. In terms of gender-specific treatment programs and services, yes, probably not. It's a good idea. And I do know, I noticed one thing that I at some point, some research on homestead programs, which sort of powerlessness, found that that is not a good model for women, for people who use and Africans. As just three, because these are who have experienced large amounts of powerlessness in their lives. So they have some powerlessness, maybe not something to suggest. As a little aside, saying that I do think because the 12 steps are the dominant paradigm for treatment in the States, it's not a paradigm that works for everyone. It's not culturally appropriate, it's not gender appropriate. So, not very specific responses.
Thank you, Jonah and Judy. Later on, we'll have another session with them. So we can continue the conversation actually on that one. One more question. We have time for that, Milosh.
Good afternoon, my name is I'm from the United States. So I just want to ask you something. Heard that you the definition of different in the States. I've seen different services. Coming from, for example, abstinence-based recovery, non-abstinence recovery. So I'm just interested now to maybe hear more about, do you have any advice on producing strategies that in environment just to shift from clearly abstinence-based right? Other.
We'll spend the next 3 days really outlining what we think of as the clinical strategies. Some of that might involve policy as well. But I think the main argument needs to be made to the public, not just to us talking heads, that abstinence is a harm reduction strategy. Abstinence reduces a lot of drug-related harm. And so it's not that it's either or. The problem with abstinence-only treatment is that it abandons the 95% of people who can't achieve that or won't achieve that right now. So what we want is to bring everyone into the world of treatment, no matter the condition of their characteristics.
I think it's really important to say over and over. Most of the people in the world with drug problems are still using it. So what are we going to do? Are we going to wait? Are we going to have preventing?
Thank you very much, Pat and GB. Ladies and gentlemen, a round of applause for Pat. At this point, we close this session and we will proceed with lunch. Lunch is served at the back of the room. We will resume strictly at 1 o'clock when I will give the instructions of the breakout. So everyone have a good lunch.